So good evening. Karibu sana to our
Good
show, Washington. We are happy to have you
evening.
here. So October is still World Down Syndrome Awareness Month, and
Okay.
we've been talking about various topics regarding Down syndrome. And this week we want to be talking about therapy. Yeah? So before
Okay.
we go right into the show, I want to ask you to introduce yourself so that the audience can get to know you and relate you to the topic of today. Yeah.
Okay. Thank you very much. I'm Washington Odhiambo, occupational. I've worked in school-based as an occupational therapy, but now I'm in private practitioner. I've been working in Nairobi Early Intervention Center as a occupational therapist, and then I moved to Bloom Garden. Bloom Garden Autism Academy is located in Lavington, Nairobi, Mudangari Road. And now from August, I started to do private OT.
Mhm.
That's me. Yeah,
So
thank you.
karibu sana. My name is Wanjugunderi, and I'll be moderating today's conversation. So we can just dive right into it. Maybe you can start by explaining to us what is occupational therapy.
Okay, occupational therapy is a professional health professional that use occupation as a mean and as an end.
Mhm.
For example, if I am a teacher, and for example I got into an accident, I lost my, maybe now amputated. How am I going to go back to that activity? How am I going to go back to what I was doing?
Mhm.
If I'm a kid and I'm supposed to, for example, to sit at 6 months, I've not sit for 6 months because of other underlying issues. What am I supposed to do to go back to the activity?
Mhm.
So use the activity we prepare to us as an occupation, as an end, and as a mean to make sure that the kid or the patient go back to his occupation.
Mhm. Okay.
Yes.
Um, so as in as much as we are talking about Down syndrome in the topic of today, I wanted to know who are the beneficiaries of occupational therapy? Who needs occupational therapy?
Of kids, people who need occupational therapies are people like maybe it's kids with special needs, Down syndrome, autism, learning disabilities, cerebral palsy, or any other condition that has affected a kid. And then now that
Mhm.
one is a school setup. Then we have also occupational therapy working in hospital setups, working with kids with people with stroke, for example, as conditions, people with maybe fractures, and then also occupational therapy working with our mental setup, a person with maybe schizophrenia, for example. So we have three major areas that you can work as an occupational therapy: pediatrics occupational therapy, mental health, and then physical dysfunction. So in
Mhm.
pediatrics, we get kids now like Down syndrome, for example.
Yeah. And in your line of work, how often do you come across individuals who are living with Down syndrome?
For where I've worked, I've met like around 4 cases of DS.
Mhm.
Three were very mild, and then the last one, the last person was very severe.
Yeah. And
Yes.
when you talk about the severe type of Down syndrome, like how, based on your assessment as an occupational therapy, when you are assessing a severe type of Down syndrome and a less severe one, what are the two like?
Okay. When you're assessing the more severe one, is one of the things
Mhm.
that is affected so much is the muscle tone. The muscle tone is affected, and other developmental milestones are also affected. So you're getting that when you're
Mhm.
working with this kid, after you have done your evaluation and you have come up with the treatment plan, it will need more of therapy. For example, if he's supposed to have 2 sessions according to the parent, you can make it like 3 sessions, 5 sessions per week.
Mhm.
And then after having done the session, now you can also give a home program to the parents. So when it is severe, it requires lots of occupational therapy intervention, and even the need of special needs teacher if there's a need of that. And then
Mhm.
then it's very easy to manage because it's mild. The child maybe is having just little sign of, for example, mosaic Down syndrome is one of the mildest that I've met. for you to look at it and come and say that now the child is having this kind of DS, you may be confused that he's not having Down syndrome. But after your evaluation, looking at the physical experience, physical features of the person, come up with an intervention. So what I always do as a therapist is I always say the earlier the better. The earlier the intervention, whether it is mild or severe, the earlier the intervention, once it is diagnosed, the earlier the intervention, the better the progress.
Mm-hmm.
Yes.
So
yes.
We've defined what occupational therapy is, and I want to ask you like a very specific question. Assuming I have a child with Down syndrome, yeah, and severe or not, moderate or mild, what are these things that you do to this child to when you're going for occupational therapy? Like, what are these exactly? Do you help them sit? Do you understand?
Yes, I understand. So a kid occupation, depending on the age, is play and then school setup. That is, so once you know the occupation of a kid is play and school setup. What are the things that have come with that maybe the DS has brought this kid that has not made him to play with other kids, has not made him to socialize with other kids, has not made him to sit down in class and communicate. So you look at the play itself, bathing, feeding, dressing, and then toileting. For example, if a kid is having they have issue with toileting. So when you are and when these are the independent activity of daily living. So when not there, even going to school is an issue. So these are also called self-care. So self-care are the ones that I mentioned. And then you have motor skills. For example, a child has been diagnosed with Down syndrome, and then is not at an age. One of the motor skills we have is gross motor skill, head control, sitting, crawling, walking, and standing and doing other stuff. Then we have also fine motor skills like holding a pen. This is also a very key factor in working with these kids. For example, if a child is floppy, muscle tone is floppy, holding a pen is going to be an issue. Sitting down and having that endurance is going to be an issue. So we give exercise, therapeutic activities that target the desired that the child needs in a class setup. And then after that, we also have, because Down syndrome, also people with this also have intellectual disabilities. So we make sure that now, because for a teacher to work with a special need kid, you must know the kid's needs. And this one is working in a multidisciplinary approach where an OT will work with a special need teacher and even a speech therapist toward the same goal. So once you have assessed your kid with occupational therapy components or areas of need, now we'll set up a treatment plan and then work with that treatment plan. And then what I always like giving is, which I always tell parents that I do therapy for their kid, that I want to make sure that when I live here, you're also a therapist. So I always give structured home program. So when I leave, because I'm there for 1 hour, then he's remaining with the kid for 23 hours. So I'm only there for 1 hour. So I make sure that the child is having a structured and a very routine OT where when I'm going, there's a home program ongoing, even on weekend. Yeah. So the first thing OT is evaluation. You are structured using a standard tool of evaluation where you look at area of needs. One is physical area, as you have motor, then fine motor and gross motor, and then you have cognitive, because they also have issues with memory. And then you have now ADL, activities of daily living that the kid maybe wanting to do. So this one is a working with this kind of kids is something that require a lot of multidisciplinary approaches.
Okay. So when you say there's a routine that you want to incorporate, I want you to talk about the importance of parent involvement when you're there as a therapist. How does it help to ensure that early intervention is effective?
Because you see, I've worked with parents who have taken their kids to India for maybe stem cell. When they come back, they're being told that the therapy should be intense. Like if you are doing 3 sessions, should be now daily sessions. They are being told to do an intense therapy. So when the parent is involved in this, in helping this is on a kid, it's also make sure that the treatment plan is doing, because maybe there's something I can achieve when I'm having a kid, and then maybe there's something that maybe the parent is the one who can achieve when he's having a kid. For example, when going for a dinner with a kid, maybe I'm not there, the parent is going with out with this kid. So what are the social issues that the parent can work on? For example, there's also an issue with behavior. See, behavior is very important, and behavior it can be done with any person that works with the kid. So maybe a parent is with him when he does something bad, you tell him to stop. When I'm also with him, it's stopping. This continuity also help in something like toilet training. I cannot do toilet training alone for 1 hour, then I leave. So toilet training should be continuing, because the child also has to go for washroom to and fro, maybe during the day. So it's when it's on diapers. How many diapers per day? When it is on sitting on the potty, they're the one who should be guiding. So activities like toilet training require a lot of parent input. Yes.
Okay. And I'm just curious to know, like, when you look back at your journey as an occupational therapist, what's your best success story?
My best success story is I've worked with a kid I was working with, and then the parent came to have the parent came and told me when you're doing an IEP, individual educational plan for a kid, the parent is involved. So a parent will come with a complaint like, I want my child to do toileting, and that's what my child to have language and communication. So that is the chief complaint. So when you're working with when you're making your IP, those are the first priority that you put. So there's a parent who came and told me that for 5 years, her daughter had never brushed her teeth. For 5 years, the daughter was 5 years old, and then she has never brushed her teeth. Why? Because he was having oral-motor hypersensitivity. He was drooling, didn't like being brushed. He was avoiding some food. Within 1 month, the kid was now being brushed normally, supported. And then the parents came to me and told me that, Washington, she came to me crying, you have done the best that I've never seen. That's one parent. The other parent who also came to me and told me that the child was not able to use a spoon. He was eating like a Muslim setup. But now after like 2 months, the child is able to scoop using a spoon. And she was very happy. So I've met parents who are making confession. I've met parents who can stand and say that because of, if my kid has not gone for therapy, is so hyperactive. It's very much hyperactive. But when the diary reads, it was seen by an OT, the child is very calm. So that's the thing that I've seen in this field of special needs education.
Yeah.
Yes.
And based on your experience with the children who are living with the Down syndrome, what is when you are giving your input as an occupational therapist, how can we support you or them to ensure that regardless of how their milestones are being achieved, they will still achieve them?
Yes, that's a good question. One, most parents with special needs kids or children, they have what's called, they have they are so depressed. They have that depression. Some of them will not be going outside with their kids. Some of them are that awareness is affecting them. They are socially isolated. So if you can move them, you can create awareness by now telling them to go outside and now make their children be like other normal kids. It can be a very better input as for me. Because getting that some parents have just their kids are just in the house. They have refused to say that their kid is maybe special because they fear. They just fear. So if you can do awareness, even because for me, I've done awareness for autism, and I've seen people are coming out because they have known it. But for DS, for example, they are in the houses, but they're not being so through you and your organization, you can be having like maybe this monthly awareness. We take a walk somewhere, and then we do the awareness. That's the first thing. The other thing is, when you are doing an IP, we can organize for some workshop, like a training where we call parents somewhere, we do a seminar for some days, so that make sure that also they also feel they're also important in the society. Because one of the things that I've also learned with special need kids or parents is after school, where are they being taken to? So most of the parents will come to you and tell you that my kid is now in class 8, for example. Now, after class 8, where is he going to take? He must go back to the community. How is community going to integrate this person to their normal situation? This is a challenge. So if we can manage the challenges, then we can get a lot of solutions. Yes.
Okay, Rose, do you have any questions so far?
Oh, thank you so much, Teresa. Maybe I would like to ask Washington, do you normally do like, do you normally do teach the parents themselves how to do therapy? And are there also, I would like to ask if at all there are those equipments, like maybe you would recommend to parents for starters, Yeah.
Okay. Okay. First, I always, because most of these parents, they are caregivers or nannies. So I always give my own program with share with the nanny. Then we, at the first 1 month, we implement together during the session. Then I leave for her to continue with the whole program. That's one. Then there are kids who have delayed milestones, for example, sitting, standing. So we can also tell the parents to come with to buy those standing aids, sitting aid if there's a need of a walker. Those assistive devices are also important in working with this special needs. So I will train the parent maybe to tie the kid to a sitting aid for sometimes, depending on the duration and depending on the level of severity. And then from there, now after I've gone, then now they can do like, for example, in a day, they can do like 2 sitting with the kid, and then as time continues, they increase the number of time. This idea of you training the parent and maybe the nanny to implement one goal is also, I've said, is also very important with these kids. So there are devices that we can prescribe. For example, the simplest one is now like electric brush. This one is most parents, maybe their kids, when I've done my session, I can do 10 minutes brushing with electric brush, and then after I've gone, now they can do the continuous. So it's like the therapy, electric toothbrush, sitting aid, standing aid, maybe walker are also very important. And then also we can also leave activities like now, for example, if it's coloring, fine motor, just coloring, we can give crayons and then a book. So I can do coloring, very simple activity.
Yeah. Okay.
Yes.
So I've asked those questions, and I gave Rose a chance to ask questions because I wanted us to address a few questions that parents had asked, because it would be because they had sent in some questions, so we can read them out. One parent had asked, "Hi, my name is Judith. I'm a mom to Nilan. How can you tell a child will speak at early years?" So this looks like a parent whose child doesn't have speech, and she would want to know how she can tell that their child will have speech. Yeah.
Okay. So for speech development or language and communication, this is an area that is also being affected so much in special need kids. So what we do, when the condition has been diagnosed, let's say at 2 years, so there are things that the child is supposed to do at 2 years, babbling, those monosyllables, mama, but so when they are not there totally, because I always believe that when a child is not verbal, is non-verbal. So if you cannot communicate, there is pointing. It's still communication. And most parents, just want the kids to do verbally, but even non-verbal is very important. So as I've said earlier, is the earlier the better. The earlier when the child is 2 years, it's very easy for you to do speech for this kid, and then he's able to achieve the speech delays. Or we have two type of speech issues. So we have regressed and then delayed speech. So regressed, the child at 2 years was doing the monosyllable, was babbling. Then after being affected condition, they are not there. One is pure regress. Then we have delayed. At 2 years, there is no monosyllable, there's no babbling and the mama words. So this one is delayed. So when the kid is, as for me as a therapist, I've met kids who have regressed and they are able to achieve. At the earlier the better. Both two can speak, but the earlier the better. Because if you bring a kid who is, for example, 8 or 10 years, this one is and has not said any word, it's very difficult to teach the verbal, but you can teach the non-verbal.
Yeah.
You can do the sign language for this 8 years. But for this person who is 2 years, it's very easy to do speech therapist for him or her, so that he can get some words. Even as he's getting some words, so you can also do the non-verbal, the sign language training of this kid. So I always do, because I've worked as a pediatric occupational therapist. So where I've seen kids with 2 years old being seen by an OT and a speech therapist, they have words. And a kid with 10 years old, it's very difficult for you to get a speech. And the speech is everywhere. When the parent is talking to a kid, it's still speech. Because most of these kids, I can tell you, they are very much receptive. Kids with special needs, they are very much receptive. The only thing they're lacking is now the expressive one. So if using the receptive one, you can use the non-verbal communication.
Okay.
Yes.
All right. Now, these are two questions, but I'll merge them. I'll read them aloud, but you can address them as one. So this parent says, a child of 9 months with Down syndrome and the neck is not yet firm. How do we go about it? So then another one asks, how can I help my child support his neck? So these two are just about the neck. What can they do to make it firm? And as they're making it firm, what can they do to be supported? I think it's one and the same.
Okay. Thank you for that. That one is a question of growth motor skills. So at 2 to 3 months old, the child should have what's called head control or neck control. Then at 6 months, it's pure sitting.
Yeah.
Then at 8 to 9 months, crawling, then walking at 1 year and above. So this kid is 9 months old. There's no head control. There's no head control. So there are things that we do to make sure that the child has achieved head control. I'm very sure the kid is very floppy. The muscle tone is very floppy. That's why he's not having head control. Head control. So what do? We strengthen the muscle, the neck muscles. And then the first thing we do as an OT, there's something called reflexes. Reflexes, when they are not they don't integrate, the kid will not achieve the required milestone, because reflexes are involuntary muscle receptors wait for voluntary. So for example, if a child has neck control issue, is not having neck control, the issue with the reflexes. So we stimulate the reflexes so that they do the work. So the activity that we do, for example, we can use the roller after doing massaging of the head. We can use the gym ball to do exercises. We can do the wedges to do exercises. And then positioning is very important. One of the things that I always train my current client is positioning. So when the child is sitting down, when she's sleeping, when she's holding the child, where is the head? Where is the head supposed to be? This is something that once we have done muscle tone strengthening, we have done gym ball exercises to stimulate, to make sure that the neck becomes strong. We give the home program now is how is it supposed to hold the kid? For example, when I'm training on sitting, how are we supposed to hold the kid when the kid has not achieved sit? This is a parent, I believe at 9 months, when her kid or his kid has seen an OT, that one is very early intervention. Very early intervention. We can use neck collars for the person, the parent who asks about what we do to the neck. There are neck collars that we use. And then when she's sitting, the sitting aid should, even the hand is very important. Like when you're seated, the hand should be where? It should be elbow height. When the hand is flagging behind, automatically your head will follow the hand. So when the hand is raised, automatically the hand will sit like this. So positioning on a sitting aid or when you're holding the kid is very important. So this parent will train two things for this parent. One, the kid is 9 months, no head control. I'm very sure there's no sitting. So we'll train on head control and then we'll train on sitting. That's why head control and sitting, we do now sitting training on a sitting aid. Those are the answers.
Oh, thank you so much. Actually, that was a very good question from that parent. I didn't think about supporting the neck. And so the other question was, where can you recommend for occupational therapy? So assuming if people are not in Nairobi, okay, let's start. For your services, how can people get in touch with you?
I'm very flexible. That's one.
Okay.
Yeah, so I do home therapy, home visits. I don't have an institution yet, but I do home therapy. So I attend to parents in their houses, or maybe depending on with this level of the condition. And then after now, I've come with my assessment plan and the agreement.
Okay.
Then having worked with in special needs for 4 years now, I can, if a parent is not within Nairobi, I can recommend therapists who are Nairobi or who are willing to work, even centers outside Nairobi. I know lots of centers that are outside Nairobi that offer lots of therapy. If it's a school, I know most of them because most of my colleagues also are also outside there.
And if the parents want to get in touch with you, do you have a social media? What content do you share?
I don't have social media yet.
How?
So this is my my WhatsApp number. I just use my WhatsApp number, and then I'm also on Facebook. Yeah.
Okay.
Yeah.
So do you want to share a number, or can they contact Rose? Can they contact Rose if they want to get to you? Like I want to know if somebody wants to seek your service.
Yeah, you can talk. They can contact Rose, or I can share my number.
Which one are you comfortable with?
Okay, let them just contact Rose because I'm very sure
Yes.
they are familiar with Rose, and Rose can make referrals. Yeah.
So then I want to know, assuming I'm at home and I'm a parent who wants to continue occupational therapy, what are some of the do-at-home things that you would recommend? Are there some tools that are readily available in the house that I can substitute or use when I'm doing OT for my child?
There's something called modification of tools.
Yes.
That is important because tool modification is also another area of, for example, the child is on a wheelchair. How is he able to do transfers on a wheelchair from wheelchair to bed to wheelchair, walking around? If there's stairs, are they around? So what the environmental modification also is a key factor to implementation of an OT plan. There are things that I allow the kids to do. So, for example, like when you're doing, there's something called normalization of muscle tone. So when the muscle tone is maybe high or low, there are things that I can do that the parent is not able to do, which are very scientific. For example, when you're doing, you are normalizing a weak muscle tone, there are techniques that you use. So if you give the parents to know to do the technique, the kid will regret. There are tools that we use. So in normalization of muscle tone, I'll do it myself. And then what I always give parents are the ADL, feeding. toileting, very important. So this one they can do because it's some when they're using a spoon, it's very easy. When they're doing toilet training, using potty training, they can do it at home. So I always give ADL as my home program.
Yeah.
Yeah, because these kids are also very sensitive. Because most parents, most kids with Down syndrome, they also have other underlying condition like maybe heart condition. Yeah, which so they're very delicate also. Yeah.
Okay. So there's something you mentioned that got my attention because we have been talking about low muscle tone, and we are talking about it as in the child is floppy, the neck is, can't stay firm. So you mentioned something about hyper muscle, like a higher muscle tone. So what is that? How does it manifest?
Okay, so we have low muscle tone,
Yeah.
also called floppy, and then high muscle tone, which is a rare case in Down syndrome, which is very spastic. The child is very spastic, very rigid. The muscle tone are so the kid with spastic muscle tone has lots of deformities. The kid with spastic muscle tone has lots of deformities.
Higher muscle tone.
High muscle tone and then low muscle tone. So,
yeah. So maybe you can just start explaining again the whole aspect of the higher and low muscle tone. Hi, did you hear me, Washington? We can start again explaining the concept of high muscle
higher
tone.
Muscle tone is spastic, and then low muscle tone is flaccid. So spastic is stiffness, and then the stiffness. Yes. Okay, high muscle tone and low muscle. So high muscle tone means the kid or the patient is very spastic.
Okay.
Hello?
We can hear you.
Low muscle tone means that the kid is very floppy, very weak. So for a spastic kid, when you are doing therapy, it's different with a kid who is very floppy. Because there are techniques that we use to normalize a muscle tone, which is very spastic, which are different from what we use to normalize a muscle tone, which is very floppy. So so when you are doing a home program, you don't give a parent an activity that goes hand in hand with this muscle tone. So you just give what I've said earlier as 8 years as a home program. Muscle tone means the kid is spastic, and then low muscle tone means the kid is having weak or very floppy. So when I'm doing therapy with this kid, both of these kids, what I do, I make sure that there are different techniques that I can do as a therapist with a kid who is spastic and a kid who is very floppy. So this activity you cannot give a parent to do because they're very evidence based and then they're very scientific. So what I can give a parent as a home program is, for example, when a kid is drooling, when a kid is hypersensitive, avoid some food. I can train the parent to how to brush so that they can stimulate these muscles for feeding and also for speech. But now when he has it with head control or the general body muscle is very floppy, I just do that at home as a therapist. Then the remaining one, I like giving ADLs as now my own program. Yes.
So thank you so much for that clarification. Maybe now we can come to the close of it where we ask you as a therapist to give a parting shot. If a parent is watching this for the first time and they're feeling discouraged or they're just in a low moment of their journey with their child, what would you tell them?
Okay. First, for parents who have special needs, maybe for the first time, what I can tell them is Down syndrome is something that is very, very manageable, depending with the therapy that you ask. So the earlier you do, and it will remain like this forever. There are skills that we also train. Getting a parent or a kid has been seen by OT, and then he or she is going to school. And then after school, you can also do that. They're also very good. Most kids with special needs, they are very good in let the kid live a normal life with other kids, and let them not be stigmatized because of different in the level of ability. Let them let the kid explore, because one of the social therapy for a kid is playing in a social setup with other kids. Let them be in a normal setup. Let them not be afraid. Let them, because most parents also get that they have gone for other intervention, maybe abroad. They have come with very, very, very other myths about maybe a condition. They also come with lots of very perception about a condition. So when they come, when they walk around looking for many other options, let them know that the best come in a normal environment is through therapy. Yes.
Okay. All right, then I think we can come to the close of the discussion. Rose, do you have any additions to make, or are we good?
No, I have none. I just want to say thank you so much, Washington, for giving us time. Huh? Yeah, thank you so much.
Okay. Karibu
Okay.
sana.
So thank you, Washington. Thank you for
Thank you very much.
the grant opportunity. Like, I've also learned, as much as I'm an advocate for people who are living with developmental disability, have been a sister to someone who has lived with Down syndrome.
Yes.
I've learned a lot that, like, I was thinking about these conversations that we are having this month, and I'm like, I'm learning so much that I didn't think that, when you are in it, you think you know, and then you have conversations with people and you're like, wait a minute, that was so insightful. So I will say that this conversation was so insightful. So thank you so much. And I look forward to meeting you at an event. And Rose, once you have events, please let us know so that we can also network as advocates, therapists, professionals for people who are living with Down syndrome and other developmental disabilities. Thank you.
True. We are going to do that. Thank you so much.
Okay.